I don't have a gavel, but I'll call this meeting to order of the Insulin Working Group. I'm Representative Michael Howard and have been co-chairing that working group along with Senator Eric Pratt. And we're here today for a 90-minute meeting to really provide an update on the work of this working group over the past 60 days, to talk about where we've reached some consensus and where there's outstanding issues, and then to hear from the public, to get your feedback about where things stand, and hopefully that can help drive us forward, because everyone up here recognizes that Minnesotans are rationing their insulin because they cannot afford it. Everyone recognizes that it's incredibly dangerous and that people have lost their lives because of it. And everyone recognizes that we have to do something about it. And the challenge we have yet to clear is coalescing around that solution and doing so urgently. So that's why we're here today. And as I mentioned, Senator Pratt and I will be kind of providing the update of where things stand. And what we want to really do for the public is show our work. Show us where we've reached some consensus, and then discuss that, and show our outstanding issues and discuss that, and then hear from some stakeholders and then from Minnesotans. So just some sort of ground rules housekeeping. We do have 90 minutes for this meeting. We're hoping to provide an update on the working group and have that take about 15 minutes. We're hopeful to hear from some stakeholders that are part of this process for about 30 minutes, and reserve about 30 minutes for public comments, and then have some closing remarks. And so those are just general guidelines. We'll try to manage our time here, but I wanted to call that out. We have a list of folks to provide public comments, and I just want to make sure that folks know that if we're unable to get to you, and please provide us written testimony. And we'll get that to the whole working group. Just overall, we want to have that sort of conversation about the work we've done, where we're at, where there's outstanding issues, and how we're going to hopefully get across the finish line. Any opening remarks, Senator Pratt?
No, let's go ahead and get started.
All right, let's dive right in. We have some information for Senator Pratt. We'll probably both of us kind of be walking through this together. The Insulin Working Group, and really all of us here, we're operating under the premise of a problem, really a crisis in Minnesota that we're trying to solve for. That the affordability of insulin is a crisis across the nation. We've heard from countless patients and families who've told us that because of that price that they are rationing. And it's, when you look at what the price of insulin has done over the last 20 years, just absolutely skyrocketed. We can see why that's the case, why Minnesotans are finding themselves in that situation. So how we got here with this working group, Senator Pratt and I met with the governor in October and agreed to a set of overarching principles that should guide our work forward to reach a consensus, that we would develop a solution for emergency access for Minnesotans that are in that crisis, that can't afford their insulin, don't have a supply of insulin and need it, to find a path to longer-term affordability so that we're preventing folks from going from crisis to crisis, to ensure that insulin manufacturers participate in the solution and do this as soon as we can. So a small working group was formed with 3 House members and 3 Senate members. For the House, it is myself, Representative Liebling, and Representative Doubt, who's unable to be here today. I had a scheduling conflict. In the Senate, Senator Pratt, Senator Benson, and Senator Wickland. And we had administrative folks from the administration with us as well as we work towards a solution. The working group first met in October. We've met several times and had several conversations that have helped sort of, I would say, clarify the problem we're trying to solve, and have discussion about where we can find area of agreement and where there's still issues, and that's what we'll kind of get into. So we'll start with the positive, where we've reached some agreements or some understandings. And generally speaking, we agree that we need to view this issue as sort of a continuum of care. Where possible, we want to help patients get a solution to their affordable insulin before they face a crisis. But for those patients that are facing a crisis, we want to make sure they have a path to access insulin immediately when they need it and can afford it. In addition, as we mentioned, we want to provide a bridge to long-term affordable coverage so that we can get people onto a long-term path to affordability for insulin. So who are we trying to solve for? Who are the Minnesotans most at danger of rationing? Well, we know the uninsured is a group of Minnesotans that could be in danger, and we've also heard from countless Minnesotans that have high deductible health plans that struggle to afford their insulin, and we've also heard from Minnesotans on Medicare that have had difficulty affording their insurance. But as we've looked at what assistance is out there already, folks that have public health programs, we want to direct those folks to make sure they have that access. Most public health programs do have access, like Minnesota Care, MA, to affordable insulin. We've agreed we want to try to prevent fraud and abuse. Basically, the situation of we want to make sure people have access to an emergency or an affordable supply of insulin. We don't want to set up a system where somebody is able to sort of pharmacy shop and get a supply at 10 different places and sell insulin on the black market. I think that's incredibly unlikely, and then patients wouldn't do that, but we want to see if we can have some structures to guard against that. We've agreed that insulin manufacturers should participate in this program, and it should be a condition of their licensure, that we should have reporting from state agencies and insulin manufacturers to ensure compliance and evaluate the program. And two ideas that came from the Senate that make sense, that health insurers will notify policyholders 90 days before an insured child turns 26 to make sure they know that that cliff is coming, that that person needs to have access to insulin, and that we direct some resources to MNsure to conduct a public awareness campaign. You know, whatever program we fashion and finally approve, we need to make sure that Minnesotans know about it. So now we're going to go a little bit more specifically into details, and this is where I think Senator Pratt and I will talk a little bit about where each of us stand. So in the areas of agreement, you know, as I mentioned, emergency access, making sure that Minnesotans have an opportunity if they're facing that crisis to get an immediate supply of insulin. So we agree that patients need to have the option of securing that emergency supply of insulin at their pharmacy. That is where patients are most comfortable. That's where they fill their prescription. We think that's the solution on that end, or one of the solutions that folks need to have available to them. For the emergency piece, we think this should be a one-time a year fill, and then finding a path to long-term, and that MNsure would be basically the portal, the site that where folks would be able to fill out an application and either electronically or with a paper copy have that right available in the pharmacy to apply for emergency insulin. So now, you know, we've talked about some of the areas of agreement. Here are some of the outstanding issues. Eligibility. You know, where the House has been at is we believe that we want to create a safety net that captures everybody who might be at risk of rationing their insulin. What that means for us is an uninsured population. And that's actually an area where I think we have agreement. Where we have a difference of opinion is the income level. So the House favors a 600% federal poverty limit income level to capture Minnesotans that might be in need. On Medicare, we think that in the conversations with Minnesotans on Medicare that there is a group of folks that have a coverage gap that makes them vulnerable to, and so we need to have them included. And we also think in terms of, we have a disagreement or an outstanding issue on how we define Minnesota resident to ensure, you know, who's able to participate in the program. And I guess for these outstanding issues, I'd ask Senator Pratt to speak to this, where the Senate's at on these. I won't speak to you.
Well, I think, I think a couple of things. Certainly the Senate recognizes it's going to be important to the House to have a pharmacy option for an emergency provision. And I'm just going to take a quick moment, because something that Representative Howard and I have been talking about is I think the Senate's position is, we're not talking about an emergency plan, and we're not talking about a long-term plan. We're talking about a comprehensive approach to how we help Minnesotans in need get the help they need. And so, we do take very, very different approaches to that. One, where I think you saw it on the other page of a continuum is really a different way of looking at it. We're looking at it, having been an operations manager for many, many years, I tend to look at things as how we can address it. But certainly, while recognizing that we will, likely have to agree to some sort of pharmacy option, we also have to recognize that there are other existing channels for affordable insulin in the system already, and we shouldn't be trying. The one thing that I think we've agreed on, and maybe isn't captured here, but at least on a premise, is that we really want to make sure that people who have access to affordable insulin, and let's beginning January 1st, right? Because that's when the new plan years start, don't need to and aren't taking advantage of the state system, that we're really trying to impact those people that are truly, truly in need. So,
So specific, though, to the outstanding issues on eligibility, I was just going to go through these. So on eligibility, did you want to characterize where?
on eligibility, I think we, again, view eligibility as a continuum, right? That the people who need access to the long-term plan are the people that we want to target for the short-term plan. And I think if you look at it in those contexts, where we've really relied on definitions within the ACA to help us define that, where the ACA has defined what's affordable in those populations that need help with medical expenses, those are the populations that we focused on.
Okay. For scope, that's another area of outstanding issue. The House favors a 90-day supply of insulin. And the reason for that is we want to make sure that there is a bridge over to the long term, that folks have the ability to receive, if they're in an emergency, that supply, and that's an adequate enough time window for a bridge to get long-term coverage. And then there also have an outstanding issue on a copay amount. The House believes, we acknowledge that we should have a copay amount. We think it should be $25, a copay amount, and the Senate thinks it should be higher. But again, I'll let Senator Pratt speak for himself on that outstanding issue of the scope.
Well, again, when you look at it as a continuum, there's a role for someone getting emergency access to roll into the long-term plan. And that we've also recognized in the long-term plan with the use of assisters that we'll talk about in a little bit, that there will be different points in time. Therefore, emergency is more about access to insulin than it is affordability. We have affordability plan. We have an affordability plan that's available to somebody before the point in time that they're in crisis. But in talking to advocates and people who live this, and even my own constituents, recognizing that there is a need for an emergency supply provision is necessary, and that's not under debate, whether or not we have a provision. That's one of the reasons we agreed to it with the governor even walking out. We would say that once we can get them into the process of the affordability program and doing the verification and getting them set up, that, and we can talk about that when MNsure comes to discuss their role in it, that a flat-out 90-day supply being handed out is really not necessary, given the other channels that we've developed.
Okay. On Representative Liebling.
I want to clarify, as you have it here on the slide, are we talking about a 30 or 90 day supply, or are we talking about just that flat 30-day supply? Has that been discussed, whether it's
The time windows, just because of the how insulin is prescribed, we've really been talking about 30, 60, or 90, just because that has been kind of the discussion. Is that answering your question? Yep. Other outstanding issue is whether to contract with a PBM to administer. The House proposal does include contracting with a PBM or a third party administer for processing claims. And from our perspective, this has a couple advantages. It uses existing infrastructure that pharmacists are familiar with, so that we can quickly process claims and have Minnesotans ensure that they can get, if they are facing an emergency, a supply that moment in the pharmacy, which is a stated goal for all of us. And it also helps us prevent fraud. You know, they have the infrastructure in place to ensure that, you know, if somebody gets their emergency fill and they get to do that fill one time per year, there would be a check against them going, you know, here, there, and everywhere. There's a program integrity piece of it, but I know that's something that is an open question for the Senate.
Well, I mean, there's a couple of things. One, we know that contracting with a PBM will violate, or I think put in question whether or not we can get this program up and running very quickly. You know, we're under the understanding that by the time we go through the RFP process and get it set up, contracting with a PBM could take 9 or more months to get up and running.
That's not our understanding.
Well, that's our understanding. And it's not going to be free. It's going to add to the cost of the program. It's going to add to, you know, we've already had a problem with PBMs on what they include on their formularies with, you know, will it be available to all pharmacies and everyone in the distribution channel? There's just a lot of questions about it. And so we think there's probably a better way to do it. We just have to figure out what that is. Some of it goes to the fact, and you'll see it later on, is that when we talk about the term of this program, in that, you know, do you view this as a permanent ongoing program, or is this a bridge to a longer term solution that will be comprehensive to more drugs than just insulin? Or are we going to be going through this process, as Representative Howard and I talked about last night, for other pharmaceuticals on a one-by-one basis? And we think that Senator Benson and the work that her committee's been doing is maybe a better solution to addressing long-term affordability on a broader scale.
Okay. Senator Benson.
Thank you, Representative Howard. We just heard two different answers on the PBM. At what point are we going to get somebody to come and talk to us so that we all level set on the same information with regard to how long it would take to contract? And I'm unclear, are we going to contract the PBM through DHS, or would there be another entity that would contract the PBM? So we haven't had anybody come in to talk about that with us, and so I think that's why we're getting some mismatches in information, because I'm only familiar with the DHS procurement process. It takes a little bit of time, and so I don't know when we're going to have that conversation about getting the same information to everybody.
Senator Benson, that's a really good question. I'll just share through the process, you know, the original bill that the House offered envisioned that DHS would hold that contract with the PBM. And so through that process and working with DHS and their timeline, we'd never heard that it would be 9 to 12 months. We heard sooner. We are having conversations about could other agencies hold that contract. The Department of Administration is one that we think could work well, and so we've had some of those conversations.
Representative Howard, I guess, when are we all going to have that conversation?
I think there are some folks here under the stakeholder piece that could speak to it.
Because I don't see them on the agenda, so I wasn't prepared to have
Okay.
a PBM conversation. I'm sorry, I prepped for who was on the list.
Let's follow up offline. I think that's a good conversation point for this group.
If we're going to continue to have the PBM conversation, then I think we all need the same information at the same time.
Sure.
The pharmacists are here, and so maybe they can talk about how they're on the receiving end of the PBM, and so we might get some new information today from them, but the PBM piece is kind of a gray area for me. I don't have a lot of understanding.
Okay.
Thank you.
Thank you. And Representative Liebling?
Thank you, Representative Howard. I just want to, first of all, I know we're way beyond, we're already over our time for our first segment here, but, you know, if there's concern about the PBM piece of it, which obviously there is, what we haven't heard is what the alternative to that is. So, you know, there's rarely things in, when you do policy, there's rarely a perfect solution to anything. Everything has a pro and con, but what we haven't really heard, at least today, is if we didn't do it that way, how would we do it? And I know we're pressed for time.
Yeah.
Just scoot through.
Oh,
So I'll
okay.
let you-
Mr. Chair.
Senator Pratt.
Senator Pratt?
Thank you, Representative Liebling. You know, part of the discussion has been that we're going to be collecting basic information on applicants as they go, and again, as we look at this as a continuum, and maybe I can start to roll into the long-term plan at this point in time after I talk about this, is that the MNsure database will have that information to be able to know whether or not somebody has actually applied and utilized their emergency supply. Because one of the pieces as we go into the long-term affordability is that they will be required to complete an application that will get them in the METs and get them evaluated. In fact, so when you think about the response to a non-PBM, it ties very, very closely into the long-term affordability plan. And in fact, you know, as Representative Howard and I have talked, even the validation on the emergency plan would be done through the same channel, through the same process as the long-term affordability plan.
So, Senator, do you want to, I think it's a segue, good segue. We are short on time, but this is important, so I'll let you talk about the long-term affordability areas of agreement.
Yeah, so one of the key values that we understood as we put together the long-term affordability plan was that it was important to have an option for patients to have access to affordable insulin before they hit crisis. It's better for the patient, quite honestly. It's safer for the patient if they're not finding out about this program at the point in time that they're rationing. We would ask MNsure to be the portal for this program. And they, you know, a patient could go to their doctor's office, they could go directly to MNsure, or they could portal through the emergency access program in order to get to the affordability program. All patients will be required to confer with an assister. And this was a term, I think we called it navigator originally, but assister is the term that MNsure has asked us to use to complete an exchange application. So that's where we will do the evaluation of the qualifying criteria. We'll be able to screen someone to see if they do qualify for a public program. Quite honestly, and particularly in our uninsured population, we don't want them to be uninsured. We want them to have comprehensive health care, and so making sure that they understand that they do in fact qualify for some of the public programs that already exist. But let's say they don't. Then we also want them to understand that going into their next open enrollment period, or what a more affordable option might be, because they might qualify for premium credits or other assistance, and they might even qualify for a special enrollment program that they don't even know about. They might be able to get into an insurance program today that is affordable for them, and they didn't know about it. As we've talked about it, that the insulin would be provided by the manufacturers. What we're trying to do is not use the manufacturers' assistance programs for this, but what we're trying to do is utilize the structure of the existing manufacturer programs to facilitate the distribution of insulin. Because we know that in order to meet that criteria of getting this program up and running, we have to use existing channels. So the outstanding issues are, as we've heard from the insulin manufacturers, they distribute through the physician network. We have, I think the one number I heard was over 265 doctors currently that are participating in the program. We would say that not only would the pharmacist, and the pharmacists, the pharmaceuticals would, as a condition of their licensure, have to participate in this program, or they couldn't sell their brand of insulin in the state. Some have asked for other options for distribution. Again, that goes to the complexity, and that goes to how fast we can get the program up and running. We've agreed at 400% of federal poverty level. I've already discussed kind of where the Senate is on that, and participation requirement. And we would also not only require the participation of the pharmaceuticals, but require the participation of doctors and pharmacists in this program.
And just on those outstanding issues from the House perspective, agreement on the areas of agreement, as Senator Pratt mentioned, and I just want to say there, I think we've made a lot of headway. I mean, I feel really confident that that we can get there and create a long-term plan that is part of a continuum of care that works with the emergency front. For the outstanding issues, the delivery method really is a challenging one for us based on what we've heard from Minnesotans. You know, we think it should be a sort of a patient choice of where Minnesotans get their supply of insulin in this program, whether it be the pharmacy, the doctor's office, or the mail order. Some of our concerns with going through the existing channel of the doctor's office relates back to that conversation of time. And can we make sure that patients are accessing the program within a quick amount of time? And we also have concerns just about the network. Senator Pratt mentioned that several doctors participate. We know of large health systems that don't participate in these programs, and I understand that the senator would just want to require that, and that's part of that from their perspective. On eligibility, you know, we kind of have the same. We're closer to an agreement on the long term, but some of the same eligibility outstanding issues. And then on participation requirements, you know, as part of this process, we've learned more about the insulin manufacturer programs, and some of those are changing rapidly. And we've also heard from Minnesotans that have had experiences with those programs. So we support a set of requirements on those programs beyond just licensure to ensure compliance and ensure that those programs kind of meet a bar that will serve patients well. Okay, we'll move quickly. There are additional outstanding issues. Funding. From the House perspective, we believe that insulin manufacturers should participate in this solution, both in terms of funding and in terms of providing their supply of insulin. And there's some discussion of, I mean, I really think the funding buckets that have been part of the discussion are manufacturers, some sort of public funding, or some sort of mix of both. And from the House perspective, you know, we are open to a conversation about a mix of funding But we believe that insulin manufacturers through a manufacturer's fee is the way to go in terms of a funding piece. And then if we want to do these individually.
Well, I would say that the agreement with the governor was that the pharmaceuticals would participate. And, you know, I don't know that we've ever proposed, we have not proposed a public funding only solution. We have to recognize that in the long-term plan, there's a real value to what we've mandated the pharmaceutical manufacturers to do. We've always been opposed to a fee. You know, and where I think we've been pragmatic on some things, we're going to need some pragmatism to get over this next piece. Now, there might be some alternative solutions to that, but you know, when we've asked the pharmaceuticals to step up and take the financial burden of providing a year's worth of insulin to a patient, we think that's a pretty substantial contribution. And you know, and so the question isn't, will the pharmaceutical companies participate? The question is, how will they participate? And to what level? And, you know, some of it I think goes to the concept of fairness. And I think each of us has a different idea of what fair is, especially when you look at, and we've disagreed on some of the information we've received, but it goes to how you interpret, I think, the cause of the problem. If you look back at the chart that was on the very first page, we see that the cost of insulin started rising at an increased rate beginning in 2010. And so that's, you know, that's something that we have to go back and look and say, where we, you know, what is the current, what is the state, what is the root cause that's driving these price increases? But also I would say that even as we've begun this process, let's talk about you know, beginning in January 1st, all state regulated plans will have options for $25 copays. And we've decided that that is affordable. We've talked to a number of plans that are managing the ERISA employer plans, and they're telling us that these employers are going to that same level. We've had information that says the Medicare donut hole is beginning to close. All of these things have started in, you know, and progressed since this conversation has started, since even since the Senate rolled out its initial plan. And so what's been extremely difficult to keep abreast of is that kind of changing landscape as we go along.
And I'll move quickly because we're behind time on these other outstanding issues. There's been a conversation, the Senate would prefer that we sunset this program in 2 years. From the House perspective, we shouldn't sunset a program that's a lifeline for Minnesotans. The Senator Pratt just mentioned the copay cap on health insurance of $25 that our plans have made for this year. We don't know if they're going to make that change for coming years. And so we think we ought to put that in state statute if it's working so well. The law that was passed last session to put that on the books so that there's that dependability for Minnesotans that have coverage. We think there should be $250,000 for assister training to accomplish some of the goals in the long-term plan, and additionally, penalties for noncompliance if manufacturers aren't truly participating in the program.
And I would say that premiums and copays change on a regular basis. Again, if we look at the reason why those copays have come down, it's been documented in the Star Tribune that it's because of what was passed last session, that we're forcing those rebates to be passed down to consumers. And it's changed the conversation dramatically since this began last year. And I would say the other, and it's a 3-year sunset, not a 2-year sunset.
Oh, excuse me, I thought. Okay.
Then also, the other pieces are just new. They weren't part of either plan coming in, and so they're new requests. But when you look at, and so, well, actually, the last 3 are brand-new provisions that weren't in either plan, and so that's why it's a little more difficult to figure out how they fit in when they really weren't part of any of the early discussions going on.
Senator Benson.
Thank you, Representative Howard. One of the other things that we haven't sort of gotten the same information on is what impact did the IRS ruling have? Because they moved insulin to, I believe it's called a preventive status, and that would put it in Tier 1 in most plans, so we haven't gotten good information on that. And the IRS doesn't change things willy-nilly, so that might actually have a bigger impact than what we have done here in the legislature, and that seems like it'd be a pretty permanent consideration. Some of the other things that are happening at the federal level that might have some downward effect, really aggressive rulemaking on reimportation pathways, and the USMCA that passed the House has a disparate patent protection for Canada and Mexico on biologics, which would, as currently defined, have a significant impact on insulin. So I think in addition to the list of things that are changing throughout the state, we have some things at the federal level, the IRS ruling, rulemaking on importation, and then the patent limit on biologics for the USMCA that are other churning factors in this market that we as policymakers need to keep that in mind as we're trying to build something. And so that might be an argument for a sunset or a review period at a time going forward once things have settled out.
Thank you. Okay, so that is our update. That took much longer than 15 minutes, but I think it's important that folks get a chance to see where we stand and some conversation about that. Next, we have 3 folks on the stakeholder piece, and we had originally budgeted 30 minutes, and we might have to try to move that through a little quickly so we have time for public comments. But we'll just continue to move forward. So I'll just ask that folks that testify, both stakeholders and the public, be brief so we can try to work our way through the agenda. Hi there.
Good morning, Senators and representatives on the Insulin Work Group. Thank you for the opportunity to speak here today. My name is Libby Cullum. Oh, sorry. Is this better? My name is Libby Cullum. I'm the Senior Director of Public Affairs at MNsure. I have just a few brief remarks here this morning. The Walz administration and MNsure as an operational partner in this initiative believe it is critical for Minnesotans to have access to affordable insulin. It is an issue that demands immediate action. We are encouraged by this public hearing and appreciate the opportunity to speak here today. It's important that we include the public's voice on this issue as we work toward a solution so all Minnesotans with diabetes can afford access to insulin that they need to survive. We support efforts to increase access in emergency situations, as well as the efforts to get Minnesotans the long-term health care coverage they need. MNsure and the Walz administration are happy to provide whatever technical assistance we can to make sure that we move toward a workable solution. We're supportive of the direction that both the House and the Senate proposals are moving in, and we look forward to continuing this work to make sure we find a final proposal that will make meaningful changes in the lives of Minnesotans. Again, thank you for the opportunity to speak here today, and I'm happy to answer any questions you have, and sorry about the mic issues.
Thank you. Are there any questions from members? Senator Benson?
Well, first of all, I want to thank you we're in open enrollment period, so thank you. We're in the last days. It's nice to be getting positive emails because the first few years, not so much. So thank you for your work on that. We've talked about, MNsure is the face of much of Minnesota's eligibility systems, and so welcome your technical support, but also that you have this unique role that you serve in helping people get into both public programs, Medical Assistance, Minnesota Care, but also the qualified health plans where they can get cost-sharing reductions and advanced premium tax credits. And I know you sent out a letter on this, so this won't be a surprise question at all. Are there any metal levels that don't have $25 or zero-cost insulin?
So all of the carriers that are offering plans on MNsure for 2020 are offering the $25 or less copays on covered insulin. So consumers would have to check with the carrier to make sure that their specific prescription is covered for this benefit, but all of the carriers are offering this plan, all four.
Thank you. We talked about, and this is something that I have talked about with you in an office meeting, having a landing page where we could consolidate some of these resources and start the eligibility process. So could you give us some idea of what data you would need to collect? And I know this feeds into the METS system. So what basic information? I just want the public to know that we're going to have to collect some information. And I don't need a comprehensive list. But in order to do this eligibility, we're going to need some information they might not be used to sharing with the government.
Right, so there are a few things that we would probably need to collect, and it would depend on exactly what the level of eligibility integrity you're looking at. So name, address, income, probably, sorry, I had a list
Family
here.
size?
Family size, yep. So, and then also if they're insured or not. So we would just have some basic information, but we're thinking we could do an initial application with 10 or fewer questions. And then, as Senator Pratt mentioned, we would hopefully be able to get the folks who have applied to fill out the longer application to determine whether or not they would be eligible for a public program or a qualified health plan.
And we had talked about attestation for the emergency plan. So attestation means we're not going to bounce it necessarily off the IRS database, which is one of the sources of data that you use. And so that opens it up to some risk, which I think is why we're looking at 30 days instead of 90 days, but that's a debate that we can have. So if we collect information on attestation, we have follow-up eligibility. Can we use the METS system for any non-ACA eligibility population?
No. So, Senator, the METS METS system uses the federal data hub to check whether or not someone is eligible for an Affordable Care Act program only. We're not allowed to use it for any other purpose. What we could do is once we get someone connected with our longer application and they're applying for a qualified health plan or a public program, then we can have them use that program.
But if they're not an ACA eligible population, Affordable Care Act, I use acronyms too much, Affordable Care Act population, we cannot run them through METS, so that if we wanted to support other populations, is MNsure allowed to do that if we fund separate program building, or do we have to do something else? I don't remember the governing rules at MNsure, and we might need to follow up on this, but are you allowed to serve any other population?
My understanding, and I'll confirm this answer, is that we can only use that data hub for ACA eligibility determinations.
As far as data sharing, Senator Pratt and I had talked about perhaps using a Minnesota driver's license as a unique identifier. And Do you have interactivity with other state agencies to check data, for example?
At this time, we do not have any data sharing agreement for that type of data.
Okay,
We would need legislation for that.
So whatever identifier we have, we might need to get data sharing permission. There has been conversation about putting the manufacturers' programs on this MNsure landing page so that if people were looking, they could find the manufacturer programs more easily. Are you allowed to share data with the manufacturers, or would we need to give express permission? It would be my preference that any data sharing, let me just start here, any data sharing would be informed front-end consent by the consumer. And then, but we would need permission. We would need to authorize you to share any information with a pharmacy, a manufacturer, a
Correct.
physician.
Correct.
Okay. Do you know, because we talked about how we're going to track this, and this might be too technical for what you came prepared for today, in the attestation document, could we create a barcode that could then be scanned and tracked? Do you know if that's something because as we collect this information, we want to have something deliverable to the consumer. They can either have electronically, but they would need to take it then to the point of contact, the doctor, physician, or I'm sorry, doctor, pharmacy, wherever that next point was. Is that something that has ever been explored?
I don't think we've talked about a barcode specifically. We've talked about ways to track these applications. I think we would need to see kind of exactly what you're hoping to track and how you'd imagine that would work to be able to react specifically to that. But I do think there are ways to track an application to make sure that we are tracking an individual's process.
And this,
Senator, I just want to be cognizant of our time. These are good questions, but I want to make sure we have time to get through folks with our 90 minutes.
okay, I haven't had a chance to have this whole group do the MNsure conversation, so I appreciate that.
I know, but your folks had said I mean, if we could go longer, that'd be one thing, but
Yep.
yes.
All right. I'm
Well,
trying to,
Representative Howard, if I might just jump in here real quick while maybe Senator Benson gets her last thoughts together. A couple of things we talked about. One, the Senate proposed a 5-day turnaround for MNsure. When Representative Howard and I met with you and Mr. Clark, we were told that there would be no problem even during an open enrollment period of turning them around that 5-day period. Can you confirm that?
I want to be careful about confirming or agreeing to anything that we haven't seen specifically in legislation. We really want to see specific details before I could confirm that.
Let me restate it. If, based on the attestation and being able to do the income, family size, there, as I recall the conversation that we had about 2 weeks ago.
Yep, the proposal that you're referring to does sound workable to us. Again, I would want to make sure we're seeing exactly what's expected so that we're not promising anything that we couldn't do, but what you are describing does sound workable if it's based on attestation.
And we also understood that based on attestation, there'd be a period of time to complete this application, and that was also considered as part of the Senate plan and how we kind of marry up and work with the emergency plan. Can you just talk about the timeline of generally how long it takes someone to get through that more detailed application process?
So you could fill out your application within 1 day. There may be things that you need to send back and forth between MNsure and the consumer if we have follow-up questions and need to verify information. So it's hard to say specifically how every application would go, but you can fill out the application, within a matter of minutes or so.
But typically, in order to find out whether or not somebody is qualified and you have the information that you need to do for the verifications through the MET system or everything, what we've talked about is generally that can be done within about a 60-day period.
I believe that's correct, but I will confirm that information.
And Senator Pratt, I think if we're going to stick to the 90 minutes, we need to move to Mr. Renner, or we could extend. I mean, I'm comfortable either way.
And I appreciate that, Mr. Chair, but again, we are trying to give an update, and this is stuff that we didn't, that really I think we need to hear from the expert to confirm some of the information that we've heard along the way if we really want to do a good update.
Okay, so you're comfortable? All right, great.
So, I mean, I think this is great, and I wish we had more time to ask questions. If I have some too, but we could always have another meeting like this. There's no rule that says we can't. So, I mean, people really want to do this, and I think it is really helpful to do it in a public setting like this. I certainly would be amenable to having another meeting like this for the purpose of bringing in experts like this one and lots of others too. But I'm going to hold my question because I do think that we made a commitment to do that out here that I really would like to hear.
Certainly. Is there another question? Or-
Nope, we already have, the Board of Pharmacy has collected manufacturer assistance programs, so I think that's one barrier to MNsure having that's been reduced. We've got a central repository for it. I think we have something here. It's the devil is in the details. Where can we get verification? What does that pathway look like? So I think we're going to start getting into the weeds pretty heavily on MNsure very shortly if we continue down the MNsure as the face of an insulin eligibility program.
That's great. Mr. Renner, and thank you very much.
Thank you.
Mr. Chair and members, my name is Dave Renner, representing the Minnesota Medical Association. And we also want to thank you, all of you, for the work you're doing on this and the leadership that you're taking to address the unaffordability of insulin, which has resulted in life-threatening challenges. Physicians, like many of you, have had a hard time understanding why these prices have gone up. We know there's been some improvements in products and delivery methods, but these kind of price increases are hard to justify. And this is not an elective product that a patient can choose not to purchase if it becomes too affordable. We are very glad to hear that the group is working at both the emergency proposals that Representative Howard has proposed and the longer-term approach that Senator Pratt has approached. We think it is critical that we have that continuity of care using Senator Pratt's terms as we move forward. We are also supportive of using some kinds of assistance programs that exist with the manufacturers. However, as I've stated in the past, and many of you have heard this, we have real concerns that if we're using a assistance program that requires that the prescriber receives and then dispenses the insulin, that will cause new administrative burdens for physicians and other prescribers, but also not be the most efficient way for patients. Most clinics currently do not dispense in their office. And as Senator Pratt said, there are, there are physicians who participate in these programs, but many do not, and it's because they are not set up to receive, to store, and to dispense insulin or other medications. If you are an endocrinologist, if your practice is focused solely on treating diabetes, yes, those do. But when we've talked to physicians throughout the state, especially outside the metropolitan areas, most say they do not participate in these programs because they are not set up and established to do so. So instead, we would encourage that you look at another type of assistance programs, and that is kind of the coupon programs that also exist that the manufacturers provide. This is where the patient would still see their physician, get their prescription, approve, potentially do whatever paperwork is needed, but then they would write the prescription, the patient would then take it and fill it at the pharmacy using the assistance card. In addition, and we think this removes also confusion for patients, because many patients are on multiple medications. So even though they have diabetes, they may have other conditions as well, so there is confusion there. At a minimum, we would ask that there at least be an option, that there be an option that the patient could receive it not only at their prescriber's office, but also through mail order or at the pharmacy. We know some of the prescription assistance programs are starting to use the option for patients to be able to have the medications delivered directly to their home. Finally, I just want to make a comment that, again, we really appreciate your looking at the affordability of insulin, but it is really important to note that this is just one of many drugs that is unaffordable. And to Senator Pratt's comments earlier, this is a much bigger issue dealing with pharmaceutical pricing. And we do have some concerns if we're going to start going kind of condition by condition for different programs. So we really ask that you all continue to work in a bipartisan way like you started last year to look at the much bigger issue of prescription pharmaceutical pricing. So with that, Mr. Chair, I'm happy to answer your questions. I appreciate your work, and we hopefully can assist you as you move forward.
Questions?
I can go or you can go.
I'm comfortable.
Senator Benson.
Representative Howard. Mr. Renner, thank you. I really hope the physicians come to the table with a let's get to yes. As you know, working with Senator Jensen, primary care is essential, and especially when you have a complicated disease and treatment protocol associated with diabetes. And so that's why we started out with, let's make sure the patient's in regular contact with a provider. We want to get them coverage, but we also want them to be in regular contact with their provider. So can you talk to us about, it sounds like you're resistant to the manufacturer's programs, and I know we have a large provider in the state that won't participate. Maybe not every physician. There is no reason for a dermatologist necessarily to give access to insulin, but primary care physicians and endocrinologists. So talk to us about, is there some place where the Senate proposal might work?
Mr. Chair and Senator Benson, we have been trying, and we will continue to try. And again, I don't want to. We really do appreciate the effort you're putting forward. We also completely agree that physicians, primary care physicians, endocrinologists, others need to be directly involved in the patient care. The challenge we found, because when we first put this forward, we reached out to a lot of physicians, mostly looking at primary care physicians, again, throughout the state. And the answer we heard is most are not participating in these programs. Now, again, it's a little different. I give Senator Pratt credit in that this is not saying we're going to use the current programs. We just want to use that structure. So we've been trying to see as a way to make it work. Many of them right now don't use the current program. Again, the main thing we hear is we're just not set up for the receiving and the storage and the record keeping that goes along with dispensing. We've asked again in regional areas of the state where we don't have endocrinologists, or smaller areas where we don't. And again, most of them will say the ones that do try to participate, it's usually if they're in a larger system or in a hospital system where there is a pharmacy already there where they can help with that at least storage, even if they're dispensing it out of their office. But most, the current we've heard right now, unless your practice is really focused at treating diabetes, we're hearing very few who are participating.
Senator Pratt?
Well, and I think Senator Benson brings up an interesting point that, not only have we talked, and we know there are some changes that need to be made. I'm still waiting for some recommendations from you on what those changes need to be, because as we talk, there are certain types of physicians that I guess can legally prescribe insulin but don't. People like anesthesiologists or orthopedists or somebody like that, right? And so that's certainly not the type of doctors that we're trying to wrap up, and I'm still waiting for that feedback from you. But I think it's been frustrating that, whether it's the hospitals and the 340B hospitals being reticent to participate in these programs and provide, and be, quite honestly, a primary channel to getting this. If the patient assistance programs are utilizing mail order and some of the others, I'm happy to take that. I mean, the goal is to use kind of the existing structure, not necessarily to mandate. But there are a number of doctors that are participating in this program, and they're not having a real, and I can understand maybe the doctors that don't have a patient currently, that might end up with a patient, have some apprehension. But I think there's got to be some recognition that physicians are already participating today. We have well over 200 that are participating today, and that given the expected kind of scope of this and the number of doctors statewide, it shouldn't be that big of a burden. I don't know if that's a question or a comment.
That sounded like a comment, but Senator Benson.
Comment to Mr. Renner. The legislature is not the primary place where patients are going to get information and care. We need doctors to come with as much yes as possible. If a doctor has a patient, comes to them and says, I gapped my insurance, I messed up, what can you do to help? We need you to be part of the yes. We don't need dermatologists participating, but primary care, endocrinologists, GPs, family docs. Let's figure out how we get to yes so that we keep talking about pharmacies. If a patient goes to their doctor, we want doctors to be at the table helping us do this right. And so I would appreciate working on getting to yes for those populations where it is most relevant.
Thanks, Senator. And if you have a closing comment, let me know. But I just want to mention, I think some of this conversation, I really want to hear from Minnesotans with diabetes and how they experience their doctor. I mean, from my perspective, I know I've heard there's challenges with getting into your doctor. And when we're just talking about prescribing your insulin, I'm not sure that is something that changes on a month-to-month basis that requires for this conversation that sort of dynamic. But I'm looking forward to hearing from the patients about that. But any just final comments, Mr. Renner, before we talk to the pharmacists?
Mr. Chair and members, again, I appreciate those comments. We have been talking, and again, we are focusing on our primary care physicians mostly because that's who are in most of the parts of the state are treating folks with diabetes. Again, they are participating in their care. They are assisting them wherever they can to get coverage and programs. I'm just telling you currently that many of them are not set up to dispense. They don't dispense. They have relied on pharmacy for other medications, and they would continue to do so for this one as well. But we will continue to try to work and see if we can find some solutions.
Representative Liebling.
Jump in here to say that we're talking about, I mean, this is one of the key places where we haven't worked it out. Obviously, we have differences of opinion, and I would just say that if we're looking to use a system that's already set up, as Mr. Renner just said, pharmacies and the pharmaceutical system is set up to dispense drugs. That's where most patients think of to go to pick up their drugs. So also the 340B program was just mentioned. We're going to hear from some pharmacists. I think that's where we can, because my understanding is that 340B organizations, it just doesn't work for this, certainly for the emergency piece of this. So that's a good segue to listening to the pharmacists.
Let's talk to the pharmacists. And you just mentioned 340B, and that kind of, we glossed over that in kind of in areas, and I would just, to Senator Benson's earlier, that seems like an option for something we need to further discuss as a group.
I think it would be important at some point to get hospitals and community health centers so that we all have the same information, because we've been talking past each other for months now.
Good morning. My name is Sarah Durr, and I'm a pharmacist and the current executive director at the Minnesota Pharmacists Association. We represent pharmacists, student pharmacists, technicians throughout the entire state of Minnesota. Thank you for listening to us testify today. According to the Minnesota Board of Pharmacy, there are over 9,000 active pharmacists in the state of Minnesota who practice in community pharmacies, hospitals, and clinics. A little less than half of those pharmacists live and work in the Twin Cities area, and another half in the greater Minnesota area. There are over 2,000 pharmacies licensed in the state of Minnesota. A number of those are community pharmacies that are open and accessible 24 hours a day, 7 days a week, and many are open later than 10 p.m. Pharmacies provide incredible access to Minnesotans, and pharmacists are the #1 healthcare professional a patient will see each year. Patients in Minnesota diagnosed with diabetes and who have been prescribed insulin for their condition by their physician predominantly have their insulin prescription filled at a community pharmacy. This is not to say a small number are filled at the clinic or by their physician's office. However, pharmacies are the predominant access point where patients receive their medications and consultations to purchase, fill, and administer their insulin medication. Insulin can mean life and death, as we know. Some patients are unable to access their medications if they do not have that access through the pharmacy. The insulin supply chain mirrors that of many other prescription drugs. Currently, there are only 3 insulin manufacturers in the U.S. market: Eli Lilly,
Novo Nordisk, and Sanofi. Almost 100 years ago, the discovery of insulin derived from animal sources literally began saving human lives. The advent of genetic engineering brought human insulin formulations to the patients in 1980. Rapid and long-acting insulin became introduced in the 1990s. Product types include short-acting, rapid-acting, and we also have that in pens and in vials. Unfortunately, the cost of insulin products has skyrocketed over the past 2 decades. According to the American Diabetes Association 2018 report, the average U.S. list price of the 4 insulin categories increased 15 to 17% from 2012 to 2016. Insulin prices increased again this year, and we see no end in insulin prices rising. For some patients who use insulin in Minnesota, depending on their insurance coverage or financial situation, the out-of-pocket cost is unaffordable. We appreciate that you, the members of this working group, and many of your colleagues are trying to address this problem for our patients. We hope that you can come into agreement that will work for patients, providers, and pharmacists. We understand that you are trying to address an immediate and in some cases a long-term problem with insulin. As you consider these policies and decisions and look to construct and put into place an emergency and long-term insulin program to address issues of affordability, MPHA believes it is not necessary to make drastic changes to the current insulin delivery infrastructure. The current insulin delivery and dispensing infrastructure is working. It's the out-of-pocket cost and the medication to the patient that we are all here to address. Really, what we're here to say is that we believe that the patients should be receiving the insulin at the pharmacy, as they work with their pharmacists on a regular basis, and they're used to picking up their medications at the pharmacy.
Thank you.
And I'll pass it off to my colleague, Jeff Lindu.
And thank you. And if you're able to keep it short, because we're tight on time. Thank you.
I'm going to set my script aside, Mr. Chair, members of the working group. My name is Jeff Lindu. I am a pharmacist, retired after working 42 years with Thrifty White Pharmacy, which is an employee-owned pharmacy chain based here in Minnesota. I think it's important to understand how intricate and important to the patient the medication distribution system that we have developed here in the United States, largely similar around the world and here in Minnesota. The pharmacies in Minnesota carry on hand a supply of medications, including insulin, that is carefully calculated to meet the demand of the patients that they serve. A patient can walk into their pharmacy at virtually any time, and the insulin that they need will be on hand. The pharmacist does far more than put a label on a bottle and answer questions for the patient. The records that a pharmacy keeps are organized. Pharmacy systems, computer systems have become critical to our medication supply system in this country and in Minnesota. The records that a pharmacy keeps as to when a patient gets their medication, the directions for that medication, the length of time that that medication should last, the other medications that a patient takes and how that medication may interact with other medications, the conversation that a pharmacist has with the patient at time of pickup are really very critical to patient care overall in the state. I'm thinking, as I was listening to Mr. Renner talk, when we build a house, we don't ask the electrician to do some of the plumbing in the house. And we don't really understand why, but the plumber and the electrician know very well why we don't do that when we build a house. I believe this situation is very, very similar. Our healthcare system is designed for patients to receive their medications from their pharmacy where all of their records are kept. And I think I'll leave it with that and be glad to answer questions.
Thank you. Are there any questions?
Well, I'll just ask one here because, and thank you for being here today. So there are, I'm just trying to find my stat here. There are hundreds of hospitals and clinics that get free insulin or reduced as, 80 to 100% back to the 340Bs. They're already in the distribution channel, is that correct?
Is that really a question for the
It is,
pharmacist?
well, it is, because they're saying we shouldn't be, they're saying that the pharmacy is the primary point, and we shouldn't be messing with the distribution channel, and this is new to me. And what I'm saying is that we've already got these 340B hospitals that are part of that distribution channel. I want to make sure that we're laying out the entire kind of current state.
I just think it's potentially a question for the hospitals. but-
The 340B system, in order to qualify for medications under 340B, the patient must be a patient of that healthcare system. That is going to leave out a lot of patients. The insulin, I can't speak to the cost of insulin through the 340B program, but the wholesale price of that insulin is the same. The cost is brought down through rebates that are paid through the manufacturer. So it is, in any way you cut it, it is rebates from the manufacturer who are bringing down the price of insulin. One of the problems with 340B, again, is it doesn't include all of the population in our state. The patient must be a patient of that healthcare system, that hospital, in order to qualify. And the manufacturer is supplying the subsidy to bring that down, regardless of whether it's through a 340B program or some other program. The manufacturer is funding that price reduction.
I do have some questions that I'll hold off on some of your statements, but I think the point is that when we talk about the integrity of the distribution system as was laid out, to recognize that these 340B hospitals and clinics do in fact dispense, and they are part of the distribution system as it is today, maybe not for everybody, and I think it's probably a wider group than, or I've been led to understand it's a wider group than what you just highlighted, but the fact is that you are not the only distribution point for these, and there are other distribution channels as we talk about the integrity of the distribution system.
That sounds like a comment, but are there any other quick questions?
Yep, and Representative Howard, I think one of the things we haven't been able to do is get the hospitals and community health centers in to talk about what they do as part of this. If we're trying to understand the full lay of the land, we haven't had a conversation with those folks. We just haven't. We don't.
And
do
happy
that.
to schedule another public meeting to do that. I think that makes sense.
Well,
Yeah,
we keep talking past each other.
that's why that makes
So,
sense.
and I wanted to thank you, Mr. Linda. So the pharmacy is at this unique juncture. You receive a prescription, the patient comes in, you most of the time work through a PBM and a wholesaler. So you've got all these intersections of the healthcare system. But I understand there's also, through the couponing system, you use a software program to communicate with manufacturers directly to get, to process those coupons. And I just want to make sure I'm not misunderstanding, but is that accurate?
Senator and members of the working group, we process prescription claims. We have basically two ways to determine payment. Cash, the usual and customary price, collect cash from the customer, or process a claim or claims simultaneously through this nebulous, and I can't begin to explain, network out there in the internet that processes securely claims between the pharmacy benefit manager or the claims processor who manages coupon programs and we send that data simultaneously into this infrastructure and get back at the same time if there's a manufacturer's coupon. That's entered into our system virtually the same way that we would enter your insurance information, a patient ID, RxBin, and PCN. And that claim goes in and the information comes back as to what we are to charge the patient and the reimbursement that we will receive. So those are done really simultaneously through the same mechanism.
And Representative Howard, this is why I asked about the MNsure barcode question, because if there's already a couponing system with the manufacturers, I don't think that's an avenue that we have explored through this third-party software processing. It might eliminate a lot of administrative complexity, but I've learned in the legislature, every time you think you're eliminating complexity, you end up running into a software problem. So I just want us to be cognizant that there might be an existing pathway, and if we could use a data system that's already in place, it might accelerate. And Senator Pratt, and obviously we haven't had a chance to talk to this, Mr. Renner talked about coupons as well. And so I don't know how many other members of the committee were aware of this, but, and this, I don't, everybody run out and say, oh, I think we found a solution, but I think we've found perhaps an alternative existing pathway that we need to understand better.
And Senator Pratt, I would just say that that's precisely why that we've fashioned a solution that would involve a PBM or a third-party administrator to use that existing infrastructure. But this issue of coupons, it's worth seeing if there's even and more we can sort of expand upon that. That's precisely why we want to use the existing infrastructure that pharmacists currently use.
If I may offer, Mr. Chair.
Just one last point, and then we got to get to public comments. Thank you.
There was a comment earlier about bringing in at least one of those providers and visiting with them. I would highly encourage you to do that. We believe that that is an existing and relatively simple mechanism that could be done to manage a program like this.
Right, thank you. Thank you very much. And we are short on time. We did start a little late, so we do want to get to folks. So I would just ask our testifiers to be kind of ready to go so we can move quickly through this, and we'll shorten our closing remarks. So first, Nicole Smith, and then is going to be Kristen Hotzen.
Good morning. I want to thank you for all of you for your time today. This bill is extremely important. As you know, there are roughly 500,000 people in Minnesota who have diabetes, with tens of thousands of those requiring multiple daily injections of insulin to stay alive. As you have heard in the past when I have shared my story of Alec, he was one of those that needed insulin, and he was one of the several people in Minnesota who have died recently as a result of not having access to affordable insulin. About a week after Alec's funeral, I received a card in the mail, and within that card was an article written in the Star and Tribune in their opinion section. And this article was written by a nurse and the president of the Minnesota Nurses Association. I'm going to read this article to you, and it'll give you a little insight on the insulin crisis. The diabetes costs skyrocket as crisis looms. Read the print headline on July 3rd. The words crisis looms literally leapt out of me because of an intensive care nurse at a level 1 trauma hospital in North Memorial Medical Center. I see evidence of what this article is talking about on every night that I work. On a recent night that sticks out in my mind, we had 5 admissions come into our 13-bed unit in a span of 5 hours. All 5 patients were having a diabetic crisis, not from taking their insulin, but for whatever reason, they were rationing. All 5 were put on insulin drips and spent several days in the intensive care unit. As a side note, the last time I checked, basic cost of an ICU bed is $12,000 a day. I've been predicting for a while now that people will be dying in the streets from diabetes alone if the cost of the drug of our healthcare crisis is not solved soon. I don't make this statement flippantly. Each of those patients were found by someone and brought to the hospital by ambulance. So the crisis is not just looming, it's here. So I understand your job as legislators is not easy. Your job is to improve the lives of people of Minnesota, and that is a great responsibility to have, and one you have chosen. And I appreciate that both the Senate and the House are working on a compromise to finish this bill. But from where I stand, it appears that some of you are looking at this crisis from a place of privilege. Unless you have carried the burden of not having a working pancreas or cared for one, it is difficult for you to understand the daily stressors. Unless you have worried about the cost of your doctor visits, the price of filling your prescription, or even how you're going to put gas in your car so you can go to work to maintain your health insurance, you cannot truly understand the fear that comes along with some of the compromises that you are requesting with this bill. We have been working on this bill for a year. Members of this task force have worked side by side with members of the diabetic community, while others have not. Valuable time has been wasted that could have been used to implement this safety net. Unless you have asked these families what they want, what they need, and what is important, you are going to fail at writing an effective bill. There are lives that are at stake, and we cannot continue to lose our loved ones because our elected officials would rather cut corners, create barriers, or turn a blind eye to our corrupt system. I don't have a lot of time today to go into detail with you. It's a complex situation, and this is why we have stressed over and over again that you need to involve us, hear our stories, because we are the experts. Every year, more than 500,000 people file bankruptcy due to medical debt. Of those who filed, 80% had health insurance. So in closing, I want to remind you that Rome was not built in a day, but those workers laid those bricks every hour of every day until their job was finished. Let's get this bill finished. Let's provide a sense of security for those who are struggling to stay alive. Thank you.
Thank you. Now, Kristen Hotzen.
Hi, my name is Kristen Hotzen, and I thank you for the opportunity to share today. 3 years ago, my 12-year-old son was diagnosed with type 1 diabetes. I would like to share now briefly about some of our experiences trying to find affordable ways to get my son the 1 teaspoon of insulin he needs each week to live and to thrive. We've tried manufacturers' discounts, Canadian insulin, and the 340B program. When my son was diagnosed, we were shocked to learn how expensive insulin was here, even with insurance. I soon learned about manufacturers' discounts, and we've tried those for several insulins. They were helpful while they lasted, but all were short-term, usually about a year. This spring, I heard about the caravan to Canada for affordable insulin. I then joined the July caravan to Canada to go to Toronto. I got a 3-month prescription filled, giving us over $4,000 worth of insulin for about $250. What a blessing. My husband and I returned to Canada in October for more insulin. We've been successful doing that so far, but I've recently heard about pharmacies in Canada refusing to give more than an emergency supply of insulin to Americans who have traveled there to buy it. Because of that, I'm hesitant to try another trip. Through a friend, I recently heard about the 340B program and the possibility of getting affordable insulin by going through community health center doctors and pharmacies. I felt hopeful when I found a participating community health clinic in our region. I felt even more hopeful when I called to make the appointment and the nurse assured me that they do 340B prescriptions for insulin. My understanding from talking with them was that they do not distribute the insulin. Instead, I would take a prescription from their doctor to a Walgreens that they work with. To my surprise, I was even able to get a same-day appointment. My excitement was short-lived, though. As my son and I were driving to the appointment, the primary care doctor from the clinic called me. She told me that she would not refill my son's insulin prescriptions. She said they refer their diabetic patients to endocrinologists at Children's, and she would not personally get involved in my son's diabetes care. I thanked her and canceled the appointment. We've signed up for MinSure for next year and are hopeful, but also concerned. One of my son's insulins, which has been especially effective for him, isn't on the formulary, and we don't know how much that insulin would cost. I want to thank you for taking the time to hear my story and the stories of others struggling with insulin unaffordability every day. Thank you for your time and effort on this committee to make insulin affordable and accessible to every Minnesotan who needs it. Your work is important and it is appreciated. I believe it could make a significant and even life-saving difference in the life of Minnesotan diabetics. Thank you.
Thank you very much. Nathan Lowy is next. And next is Annette Gentile.
Thank you. My name is Nathan, excuse me. My name is Nathan Lowy, and I am a type 1 diabetic of 30 years and father to my 9-year-old son who has been type 1 for 3 years. I'm wearing this life preserver today because as this preserves my life in water, this preserves my life every minute of every day. I can rely on my life preserver to keep me afloat. However, if I cannot access my life preserver in an emergency, I will die. I'm exceptionally concerned by the proposed cost for this program. We have most insurers that have capped the co-pays at $25 per fill. However, we're looking at the potential of up to $100 for an emergency program. If, for example, I lose my job, how am I supposed to afford a $100 fee to keep myself alive? I'm very glad to hear that a combined bill has been proposed, as a combination is a much stronger bill with a much broader range of people eligible to receive assistance. However, I'm heavily concerned with the push for this program to be managed by physicians and distributed by physicians. As we already heard, pharmacies are already set up to distribute medication. Physicians largely are not. They're responsible for writing prescriptions and adjusting dosages, not necessarily distributing the meds. On top of that, the average endocrinologist in the state, and from my own personal experience, has a wait time of multiple months to get in to see them. And in many cases, you cannot simply call them and ask to go pick up medication or a form or anything from their front desk. You have to make an appointment to physically see them. In these cases, we don't have weeks or months to wait. We have hours, maybe days if we're lucky, if we're in an emergency. I'm also perplexed by the proposed sunset of the program. If we are looking at this only being active for 2 years, what's that saying to our 23-year-olds who are going to age off their parents' insurance in 3 years? What's that saying to my 9-year-old son when he turns 18 and is on his own insurance, or 26 and is on his own insurance? Is his life important too? I'd like to share actually a short letter that was sent home with my son from a friend. He is in 3rd grade. He is 9 years old. A friend of his gave him a note that said, "To Jet, my son, here," basically paraphrasing, "here is money for what you need. Use it for what you need." And attached to the bottom of it were taped 4 quarters. This was following a discussion about his diabetes, and his friend knows he has diabetes and knows how much the cost is. If 9-year-olds can understand this, why are we still struggling to find a compromise? In conclusion, and while the long term is important, I cannot worry about it if I am not alive in 5 days. We must have an emergency component to any agreement, and that emergency component must be easily accessible in a timely manner to any insulin of the patient and doctor's choosing in Minnesota in an emergency. Bottom line, if the points that remain a conflict would not have saved Alec, then there is still movement to be made and work to be done. Thank you.
Thank you. We have Annette Gentile and then Alexis Stanley, and I'll note we're a little long on time. We did start late, so I think we have time to hear from our last 2 testifiers.
Hi, my name is Annette Gentili, and I've been type 1 diabetic for 32 years. I am currently on disability because I've had 4 heart attacks due to my diabetes. I'm in the Medicare donut hole. It is not closing. I make roughly $16,000 a year on disability. My insulin is $11,000 a year. That leaves me with $5,000 to pay for a supplement, a place to live, and in Minnesota, you cannot find rent for under $100, I'll tell you that much, and to pay for food for me and my 17-year-old. If we don't get something soon, this is a big problem, not only for me, but a lot of my friends who are also type 1 diabetic. I go to the International Diabetes Center. As you know, it costs money to go to the doctor too. So with my $5,000 that I have left in a year to go to the doctor, if I would go be into an emergency situation and have to go to the emergency room, there would be a lot of money that I would have hospital bills, which I do right now. I talked to my doctor yesterday about this, and he said they don't want to worry about having to store this insulin. They don't want to have to worry about trying to figure out who is eligible. They don't have those means. He is a doctor, and he wants to take care of his patients. He wants to be able to he sees hundreds of patients a week, and he wants to be able to take care of his patients, and his patient care is more important than trying to figure out how much money they have. So he needs it to go through the pharmacies. It's already set up there. It needs to just continue to go through there. It would be easier for him as a doctor to take care of me or my other friends and other diabetics to write a prescription so that we can just go to the pharmacy and get the emergency insulin. So thank you for all the work and letting me speak today.
Thank you. Alexis Stanley.
Hi, my name is Alexis Stanley. I'm 20 years old, and I'm a junior at Concordia University in St. Paul. I'm going to be honest, I'm kind of having a little deja vu talking to you guys because this time last year, I advocated and spoke for the first time at a roundtable with multiple legislators addressing the high cost of insulin and my fears of turning 26. A full year has passed since then, and I'm now 1 year closer to having to face my biggest fear, and I feel like nothing has really gotten done. It's been 62 days since I stood in solidarity with Governor Walz urging for immediate action to get bills passed for affordable and emergency insulin. In the past 62 days, the retail price for my diabetes has cost roughly $2,435. That is 5 times the amount that I pay in rent a month, and that was only 2 months of the cost of living with this disease that I will have to pay for the rest of my life. There are people struggling to pay this amount out of pocket. When I turn 26 and get off my parents' insurance, that could be me, and I know for a fact that I will not be able to afford this disease if I'm uninsured. It's always, have a good job at 26 with good insurance so you can afford insulin to stay alive, and never, maybe we should make life-sustaining medicine affordable. That needs to change, and that's what we're here pushing for, making life-sustaining medicine affordable and access to emergencies and accessible in emergencies, and we can't do that until an agreement is reached. There's no reason that over the last 62 days that an agreement hasn't been made, but until one is reached, more people are going to be rationing their insulin and going broke trying to stay alive, and that's on the ones who are in power who can make a change that haven't done anything yet. Thank you.
Thank you. And we're short on time. I think we'll make a few closing comments. I want to thank everyone who came to testify here today to share input on the bill. I think that helps us move forward, and I hope it was instructive to the public to get a sense of where we stand, what are the issues where we've reached agreement, and what are the outstanding issues. We have made some progress, and we've worked together to do that. I think now is a time for us to all feel that sense of urgency to get us across the finish line. I think this is a very helpful meeting to do that, And I don't think there's any reason why we can't continue our work together and get this done by the end of the year. We must feel that sense of urgency to solve this crisis. We've done good work to move the ball forward. It's just about getting it across the finish line. Senator Pratt?
Well, you know, I've been asked on many occasions why I'm doing this. I'm a banker and a finance guy, and I'm not on any of the healthcare committees. And I've got some personal reasons for it, but mostly because we know that insulin is unaffordable. I mean, insulin has been unaffordable to a number of people. We've heard the stories, we've heard the testimony. You know, maybe just a couple of points of clarification, you know, just real quick. You know, when we talk about the doctor, we're talking about getting that prescription sent to the manufacturers. That's something that they've said they've needed. Just to clarify for everybody here, and we've clarified it within the working committee, but it doesn't feel like it's been kind of clarified here in the public, that this is not a full-blown appointment that takes months or weeks to get into. What we're talking about is just simply an administrative function to move that prescription over so that the manufacturers can comply with the system that we have. There's no argument that a final solution will have an emergency program. That's not even in debate right now. And so while I appreciate that, I just want to make sure that that's clear. But also we recognize, and I want to thank Mr. Renner for his comments, that while insulin is extremely important, and I've been hearing more and more stories from my community since I've been involved in this, it's also part of a larger problem that I know Senator Benson is trying to take on. So, you know, with that, you know, let me just say I agree with Representative Howard. I think we all feel a sense of urgency. We have to keep moving on this. The primary goal of the Senate has always been to connect patients with insurance, and I think you see that in our plan. But really, that we're committed to a bipartisan solution on this. We've been trying to take the politics and the rhetoric out of this conversation. And, you know, I appreciate working with Senator Howard on this hearing to make sure that we did that. I know Senator Benson is extremely interested in this issue. Senator Wickland has worked on it for a long, long time, and they have been great to work with. And so, but we hear you, and we're continuing to push forward, and I know that we feel the same sense of urgency that you do, even though it might not always look like it.
Are there any other members that have closing comments? Senator Wickland.
Yeah, and I don't want to take much time, but I do want to express a couple things. I really appreciate that we were able to have this meeting today. I appreciate being able to hear from the public members, their thoughts, their initial reaction to this opportunity to hear an overview of the proposal. I'm sure that they will need some time to think about maybe all of the reasons that, you know, all of the things that they might have questions about. I think it's a lot to take in, and so I hope that they will continue to provide us feedback on what they've heard today. Definitely appreciate being able to hear from the public what they're facing day to day and in their lives. And I hope that this means that we will continue this process and have more public meetings, because I think a lot of the information that came out was really helpful for me to hear and helpful for the public to hear as we move forward. Also, I just, it came through to me that, you know, we have this common goal to use existing frameworks and structures, and I think that's a great goal. And I think that now we need to move to listening carefully to the people who are coming to us, either the stakeholders who we're asking to participate in the program, and listen carefully to what they're saying and take action and provide feedback to them on how we want to implement the program, so that we are actually using existing infrastructure efficiently and getting a program set up quickly. And finally, I just also want to express that I hope we continue to have a sense of urgency about this, because it's truly is an emergency that we address, and we need to do our work to create the solution quickly and an effective one. So thank you again for holding the hearing today.
Thank you. And the last thing I'll just say is if there's members of the public that are watching or here, please send us feedback in writing, either to myself, and we'll get that feedback, or to Senator Pratt, and we'll get that feedback to the entire working group. With that, this meeting is adjourned.